As Ajay said, I'm going to be talking to you about treating an infected TKR using a two-stage procedure. Let me see here. Now, first of all, I think it's important to define what we mean by an infected TKR. We see lots of total knees, which are a little bit red, a little bit swollen at 2 weeks. And I think the important thing is you should avoid using antibiotics until you've actually proven there is an infection. So early infection up to 6 weeks, it's possible to save the prosthesis if you do an early washout, either open or arthroscopic. If you do an open one, always change the polythene on the tibia if you can, if it's not a monoblock. However, after 6 weeks, it's really a waste of time to consider doing anything like a washout arthroscopically or open. And we would then define that as a late infection. And I think then if this is established with microbiology, then the prosthesis has to be removed. So definition of infection, where you get pain, swelling, redness, a significantly raised CRP, an aspiration would show an increase in white cells. Hopefully you would culture a bacteria, particularly if you culture it for long enough. And the other thing is, don't just use swabs, take fluid and put them in blood culture bottles. Otherwise, a lot of the time you'll get a false negative. Histology is very useful if you've got a good histologist to look at the number of polymorphs in a high power field. And bone scan is sometimes useful, but it's questionable. It's very difficult, I think, on a bone scan to differentiate between an infected loosening or an aseptic loosening. But if ever in doubt, always err on the side of it being infected if you're not sure. So with the gold standard, I think now for diagnosing an infection is doing arthroscopic biopsy, or if you want to do open, you can. But I now do an arthroscopic biopsy. I take 5 biopsies, 2 from the suprapatellar pouch, medial and lateral, 2 from the medial and lateral gutters, and 1 from the area of the fat pad. And that's sent off for both histology and culture. You can use pituitary rongeurs. They're very useful to do this. And they should be cultured for at least 14 days. So what's the treatment options? Well, in a few patients, elderly patients, those who are too infirm for further surgery, you may consider antibiotic suppression. And I have one old gentleman who's got a wound which weeps every now and then when it starts weeping, we put him on an antibiotic. And he can still walk, he can bend the knee, but he's too unfit to undergo any further surgery. Arthroscopic open debridement, as I've said, is useful before 6 weeks in about 30% of cases. And then we come on to explantation, and this is where it's divided into the 2 different types, 1 stage and 2 stage. Failed cases, you may need to consider arthrodesis or amputation. I don't think resection arthroplasty is an option in any patient, personally. Now, there are some proponents of 1-stage surgery who say that this is the gold standard, particularly my friends at the Endo Clinic in Hamburg, who do all of their revisions for an infection in 1 stage. But one has to say they've got a fantastic unit which is set up to do this. They have a histologist and microbiologist who does nothing else but look at their infected specimens. They can do frozen sections and slides at the time of surgery. But the problem is, if you go in to do a 1-stage surgery, you have to cement the stems, and it really means there's no second chance. If you get a reinfection, the next operation is a significantly difficult procedure. You can't go in for a second debridement. The whole thing has to be removed. And the other problem is that you can't, at the time of surgery, often give the relevant antibiotics if you haven't got cultures and sensitivities. So the 1-stage revision is radical debridement, frozen section at surgery, completely cement the stems, and use a constrained prosthesis. Not recommended if you don't have a bacteriological diagnosis at the time of aspiration or biopsy. Also, not very useful if there's bad skin problems. You may need to get a plastic surgeon involved to do a flap, and that's always done best with a 2-stage procedure. So the 2-stage revision, what we now call the gold standard. Cement spacer blocks have been used for a long time, but now have been superseded by articulating spacers, either made out of bone cement or by using the prosthesis you've taken out. Now, this can only be done if you have an autoclave on site. And in the UK now, this is becoming less common, so we can't do this. The prosthesis is removed, the cement's removed from it, and it's put in the autoclave and sterilised. This includes the polythene. Then you can then put some cement on the back of the prosthesis and loosely cement it, if you can understand what I mean, into the femur and the tibia again. This means that the patient then has a spacer which they can move during the next 6 to 8 weeks, and at the time of the second stage, it's easy to remove. And results have shown that this is significantly better than using a fixed spacer. So with 1 versus 2 stage, obviously with 1 it's a benefit because there's only 1 surgery. With 1 stage you must cement the stems, 2 stage you can use press-fit cementless. You have to use a constrained prosthesis in 1 stage. With 2 stage you can usually go for a PS or a semi-constrained, but I tend to use a rotating hinge in most cases. The antibiotics locally are high in the 2 stage because you know exactly what the cultures and sensitivities are, and you can add these antibiotics to your cement. And it doesn't matter if that weakens the cement, it's only a spacer, it's going to be removed. The bacterium has to be identified if you're doing a 1 stage. It's not so important at the 2 stage because you can culture the sensitivities during the gap between the first and second operation. However, the success rates are similar. In the 2 stage, most of the literature shows the success rates are 90%, whereas in the 1 stage, 70 to 80%. However, how do we know this? If you look at the literature, there's very few papers on the left-hand side about 1 stage revisions, whereas on 2 stage there are many papers that have been published. Spacer blocks, so the articulating spacer, as I said, is an advantage. It needs to be autoclaved and then loosely cemented back in place, and there's an example of one there on the right. Cement spacers is something I use. The company supplies a mould. They don't supply it, they sell it to you. And then you fill that with a low viscosity cement, and you make a cement spacer which then can be inserted in the knee. These are very functional, and the knee can bend. I have one old lady who's had it now for 10 years, and she will not let me do the second stage because she's so comfortable. With antibiotics, it depends on what you use normally, but with a 2 stage you can see what the bacteria are sensitive to and add those antibiotics to your cement. Postoperatively, we tend to use ticaplanin and rifampicin for 1 to 2 days and then follow up with an oral antibiotic which is relevant to the culture. Postoperatively, they get daily physiotherapy. They are encouraged to bend the knee and to partially weight bear with crutches. And then reimplantation can then occur at 6 to 12 weeks later, sometimes later if the infection has not been cleared. We did a prospective study some years ago with 33 patients. There's the demographics. The spacer time on average, because we used a mobilizing spacer, was 15 weeks. Mainly Carag-negative Staphylococcus staph aureus. We eradicated the infection in 91% and only 3 patients had a reinfection. Now, if you look at all the literature, that's roughly about the same sort of figures you'll get from most of the papers, between 73 to 100% in most of the papers which look at 2 stage revisions. And there we are. Here's a case that I just brought up. A 58-year-old man with 3 prior surgeries was on antibiotics for 14 months before he was referred to me. We did a 2-stage revision. This was a methicillin-resistant staph epidermidis. Had an excellent result, and he's 32 months post-op and has had no evidence of reinfection. So in summary, I would say that 2-stage revision remains the gold standard. An articulating spacer allows good function, it gives high patient satisfaction, and the eradication rate is around 90%. It's cost effective and has excellent clinical results. I thank you for your attention. We've got 1 minute for questions.
Revision, if the patient comes late to you, we usually see lots of bone gaps or defects.
Yeah.
Would you like to fill this defect with a graft or with the help of some sort of wedges?
I'm very keen on using trabecular metal cones now. I find them very useful, but I think you can use what you're used to. I think bone graft you have to be careful. I think in infected cases doesn't do well. If you've got small gaps, wedges or spacer blocks are useful and you have to use them. In an elderly patient, there's no reason why you can't use cement with a long stem. That's probably a reasonable thing to do. But the new trabecular metal cones are very useful for rebuilding the defects.
How long do you give IV antibiotics, and what about oral antibiotics?
We try and keep the IV down to 4 or 5 days. If you have to give it longer, then you've got to put in either a PICC line or some deep line, which is a bit of a nuisance for the patients. It depends on what you grow at the time of the culture and sensitivity. If you can find a decent antibiotic which is oral, I'd rather get them on oral, get them moving, and get them out of hospital.
Early infections, you said it resolve the prosthesis.
Could you please go to the mic so that the others can also hear your question? There's a mic because
Early infections.
Yeah, the question is about early infections, retain the prosthesis.
If patient develops a sinus or fistula,
Oh, it has to come out. Yeah, if they've got a fistula or sinus, you're wasting your time with a washout or debridement. Yeah, the ones I'm talking about, the patients you see at 3 or 4 weeks, it's a little swollen, you bring them in, you do an aspiration, and you grow a staphylococcus. Now, at that stage, you've got nothing to lose by doing a washout, debridement, or even doing an open washout, removing the polythene and changing the polythene spaces. You may get away with it. Your chances are about 30%, the literature shows. And you've got nothing to, at that stage you can do your biopsies as well. And then if you do not eradicate the infection, you then just proceed to do a second stage.
John, if I may ask a question, roughly in what percentage of your patients were you able to
Identify the organism.
Sorry, identify.
Identify the organism. What percentage roughly?
With the open biopsy type, usually about 85%, most of them.
And get a sensitivity profile as well.
And get a sensitivity, yes. But very occasionally you've done your second stage and suddenly a late result comes back and surprises you, something you never had before, and then you just have to change your antibiotics you're giving them post-op.
When has the organism been tubercular?
I haven't had one yet. None in my series. But yes, it will happen, I suppose. Good?
I think, thank
Thank you. Thanks a lot.